Okay, well, welcome everyone. This is I'm Dr. Elena Rios, President and CEO of the National Hispanic Medical Association. We are having monthly COVID-19 virtual briefings with speakers from around the country to give us their expert opinion about how the COVID-19 disease is impacting the Latino population and especially essential workers and those who we need to get the message out, how important it is to get vaccinated and how important it is to get care. We know a lot of Latinos are uninsured and are outside of the healthcare system. So we look to all of you who are on this briefing to let your friends and colleagues know some of the important information that will be shared today. Today, our topic is variants, the COVID-19 variants, and the uptake of vaccinations among Latinos. And it gives me great pleasure to introduce our speakers. We are going to have a presentation by Dr. José Montero, who is the director of the Center for State, Tribal, Local, and Territorial Support at the Centers for Disease Control, Disease Prevention and Control, CDC. We have Paul Juarez. Dr. Paul Juarez is a professor and vice chair of the Department of Family and Community Medicine, Health Disparities Research Center of Excellence at Meharry Medical College in Nashville, Tennessee. We have Paulina Rebolledo. Dr. Paulina Rebolledo is assistant professor of medicine and global health, Division of Infectious Disease at the Emory University School of Medicine and Rollins School of Public Health in Atlanta, Georgia. And we have Laura Castellanos, who is a board member of the National Association of Latino Healthcare Executives and also an associate director with the American Hospital Association out of Chicago. So we're very happy to have all of these experts. And I want to thank our sponsors, AARP, Teach for America, and the chat box just went up, so that's the National Association of Latino Healthcare Executives. And I wanted to go ahead and also thank all of our staff who are on this webinar helping with our program logistics. It is a CME event, and we have CME for all the health professionals online. Next slide. So we just wanted to give you some housekeeping rules before we start. We have one major presentation to provide data and information to set the stage, and then it will be followed by a question and answer discussion. We invite all of you to type your questions in the Q&A box, and microphones will all be muted. And then we have a post-webinar survey that will be emailed out to those who have registered with instructions to claim your CME next week. We will also have this recording on our website, which is NHMAMD.org next week. Next slide. And this is the CME notification. No one has anything to disclose. And there is a website there, the NHMAMD.org/COVID-19-virtual-briefing-series to get your CME. Next slide. So at NHMA, the National Hispanic Medical Association, we've been fortunate to be funded by the Centers for Disease Control and Prevention to be able to have a national campaign that we call Vaccinate for All. Next slide. And that Vaccinate for All campaign includes support also from Johnson & Johnson. And it really, the goal is to provide individuals, whether they're physicians or other health professionals and our partners, and also organizations to be able to share information, the latest information on how to encourage our communities, especially the Latino community, to get vaccinated. We do this through social media. And next slide. And we have a slide here about who our champions are. You can be a champion for us. Anybody that wants to be an ambassador that would share messages from social media. And also you can help film small videos that we have on our YouTube and on our website. And as an organization, we invite you to be champions so that we can have more members of your organizations also help with collaborating with the resources that we have. Next slide. And I really want to thank everybody that's here today. Next slide. I don't know if there's another. Okay, so I want to thank everybody that is on the program and want to thank especially the champions for Vaccinate for All. I think we have over 200, 250 champions at the moment, and we are recognizing all of you on our website and trying to build our chapters around the country with more champions in different major markets. We're also doing media training, especially of some of our leaders within the organization to help build more messaging for the champions to spread out through their own networks. So thank you very much. So it gives me great pleasure to have the presentation done by Dr. Montero. Dr. Montero, do you want to take it away? And if you just tell our staff when you want to advance your slides, they will advance them for you. Thank you very much.
Thank you very much, Dr. Rios. Thank you very much for the invitation. It's an honor to be here with this amazing group of panelists. I will go over some basic data. Next slide, please. That will help us get situated in where we are today in COVID-19. And I emphasize on today, and I think that I need to say August 24th or 25th, because something that we have learned with this pandemic is that it changes. What we were talking about 6 months ago, 3 months ago, 1 month ago, is not necessarily the same type of thing that we are talking about today, which adds incredibly to the complexity of messaging to the communities and to the providers, because many pieces of information have changed. So I'm going to run through all of the different things that you see here in this slide quickly. The slides will be available as a PDF presentation later on. Next slide, please. So let's start with the variance, right? What is a variance? It's any of the different strains that you have of any particular microorganism. And in this particular case, we started COVID-19 with one particular set of strains that have been changing. And it will continue to change. They will continue to change. And they change in many different ways. Some don't have any particular impact in transmissibility or in severity or in whatever, and some do. We have been able to identify specific mutations and changes and translocation in the different strains of the virus that allows us to know which ones may be more transmissible and which ones aren't. We have many of these pieces of information in our website. Next slide, please. So when we talk about variants, the most common ones, remember, I don't know how many months ago, we were all talking about the B117. And back then we called it that, BB17. And sometimes in the media, they refer to it as the UK variant. There was final agreement to use Greek letters to identify them. Actually, in one of those things that we need sometimes to realize that when we start calling things by a name of the country, people start to discriminate against people who come from there. So that's why we nowadays talk about a Delta variant, because the fact that it was first identified in India doesn't mean that it generated there or that that was the only place where that mutation occurred. So it's better to have this type of terminology. Here in this slide, you will see some basic information about four of the most, what we have had as four of the most frequent variants. So as I said, the UK variant, the B117, was with us for many, many, many months. First identified in Europe and the UK specifically. And we start to see that that one took over everything. We first saw it in New York, and then from there it spread, right? We know that the vaccines that we have here in the US work quite well against this one. We have the B1351 or beta that was identified in South Africa. We know that that actually has quite good speed to spread that several of the other variants that we were seeing at that time. But then it didn't take, because that one and P1, which is the one that was identified in Brazil and Japan, were overtaken by Delta. Delta first was identified in India. The thing that is clear with Delta is that it spreads much faster than any other of the variants. The infection, the transmissibility is quite higher than with other variants. We know that the vaccine works for this particular variant, and we know that most of the monoclonal antibody treatments that were developed last year still work against this variant. And you are seeing many different deployments of those monoclonal antibodies across the country to provide treatment for those who are unfortunately ill with this particular disease. Next one. When we talk about the variants, specifically with Delta, so more contagious, we know that. It is at least twice more contagious than the other variants that we were looking at. There is some data that is not conclusive, and I want to be categorical on that, that it may cause more severe illness than previous strains in unvaccinated people. The thing is that we are seeing this dramatic increase in the last 6-8 weeks that we haven't had enough time to measure many of the things that we would love to measure to provide that information to you for clinical practice. Now, still today, unvaccinated people remains the greatest concern, because we are seeing, and I will show you later the numbers of cases of, and most of those are unvaccinated people. So the goal is still to get to the unvaccinated and get them vaccinated. Because from there, it's spreading to the people who are already fully vaccinated. It started as a slow percentage, and we have seen dramatic geographic variability and breakthrough disease in this country. In some areas, it's still 1%, less than 1%, in other areas, it's way higher than that. The only thing that we know that it seems to be is that people who are vaccinated appear to be infectious for a shorter period of time. So it's less severe in them, and they are infectious for a shorter period of time. So I was going to advance a slide. Next slide, please. So look at this dramatic progression. The yellow one is Delta. The blue one is Alpha, the UK and variant. And you see back in May 22nd, 75% of the cases were B117. And based on the samples that are collected across the country, that's the way that this graphic is developed, with data that we collect from all around the country. We saw how in a few weeks, Delta spread and took completely over. And for the last couple of weeks, it has been 98, 99% of the prevalence of the strains, the different strains. Of course, you have, within Delta, you have the AY2, AY1, AY3, which have some specific genotypes differences and even some behavioral difference. But for all practical purposes, all of those are Delta. And a month ago, we have different pockets where the disease was more prevalent. Next slide, you will see today that when we break down the country by what we call the HHS regions, the Health and Human Services regions, there is no difference. The whole country is basically at the same place today with Delta. Is this going to stay? Is it going to be several more months here? I don't know. And that is what we have, a national program of surveillance of these variants that allows us to see what's happening, what is coming up, and what may be the next one that we have to find. Next slide, please. Because this if remember the previous graphic was, I'm sorry, can you go back one sec? The previous one. I just want to highlight a point. Look at what, I am using my pointer here. It's killing me that I don't have control of the mouse. When you look at this graphic and you look at the last 6 weeks, you see how Delta took over. Now go back to slide 15, please. We were all so happy we were done with the pandemic, right? We got the vaccine. We were getting people vaccinated. We were going to be out of the pandemic, and then Delta took over. And you see the clear correlation with the number of cases and the quick uptake that we have seen since end of June, middle of June. When you go to the previous graphic, you can clearly see that this is an overlap between Delta and this increase. Now, when you look at the number of cases, at the cases per 100,000 population, this is a rate, you will see that not everybody gets equally impacted. And people have been impacted differently at different times. Let's, just for sake of discussion, look at Black non-Hispanic, which is one of those dotted lines. And apologies, I don't know what color that is. I am really bad with colors. So you look at the line and you see that early on, it was not the group that was experiencing most of the cases as a rate, and it never was until now. So something has changed in the way that the disease is spreading in some particular groups. When you look at American Indian Alaska Natives, you have seen that you see, I don't know if that's yellow or green or whatever color, it's one of, that's the problem with me and colors. But you see how American Indian, Alaska Natives, and Hispanics, that is the blue-green line, I don't know, that you see there, that are solid lines, have been mimicking each other from the very beginning and having the same type of peaks and the same type of increases as we see today. So those are the groups that, for whatever reason, are being exposed the most and getting the highest number of cases. Next slide, please. And this is quite clear when you look at how many cases we have had in these different populations. To the left in red, I think that is red, you see that Hispanic Latinos are in theory 18% of the US population, but so far 28% of the cases have been in that particular group, which is a dramatic contrast with what you see with white non-Hispanic or with Asian non-Hispanic. When you look at Black non-Hispanic, they are closer. American Indian Alaska Natives have the same phenomena in number of cases that you see in Hispanic Latino population. But then when you look to the right of this graphic and you look to the blue, whatever, this side of the graphic, and you look at mortality. Mortality in Hispanics is not that high. But mortality in American Indian, Alaska Natives, and Black non-Hispanics is higher. So exposure, illness, and fatality and mortality are related, but they have different components. That, and this is something that maybe is good for the discussion later on, is an issue of access, it's an issue of pre-existing conditions, it's an issue of the age at which these patients are being exposed, it's an issue of poverty. So we can discuss that. We have experts in the panel that can lead us on that discussion. The next slide. So what are we doing beyond all of the messaging and the mask and all of these different things? Well, we are vaccinating. We are advertising the vaccination. We are pushing for the vaccine, educating people for vaccines. Right now, at least 200 million of people in this country have received one dose and 171 are fully vaccinated. When you look at this number by percentage, you see that people that is over 12, 70% of the population is at least with one dose. But look at the last line, 91% of people who are over 65 have one dose, only 80% of them are fully vaccinated. So we started this in December. We have been doing a lot of education, encouraging, working with people, making the vaccine incredibly available, because the people that we saw dying at the beginning of the pandemic were people over 65. Today, we have 80% of them vaccinated. When you put together 80% of people over 65 fully vaccinated, 90% vaccine efficacy, and increased Delta, in the Delta strains of cases going up, you know what's going to happen. And that is something that we want to prevent by increasing vaccination. As much as we can talk about the booster, the goal still is get the primary series complete, get these people vaccinated is what we need to continue to work on. Because you look at the next slide, there are differences. I am not going to present a lot of things in age group that I'm going to show you here, vaccinations by rate. And you see the top line here. It is the American Indian Alaska Natives. American Indian Alaska Natives are leading the nation in vaccination. Actually, with many of the reservations, they are helping the system vaccinate people who are not part of the tribes or the reservations. So that is really good. We look at Hispanics here, which is the other solid line, and you see how there has been an uptake and how it gets closer. When you look at the graphic in the right, the rates of 2 doses are getting closer to the ones for white non-Hispanics. When you look at the 1 dose, we may even think that has surpassed white the first doses. And all of this has been a push in the last several weeks. It wasn't happening before. It has been happening in the last several weeks. But you see here that there is a line that is not catching up. Black non-Hispanic Americans are lagging behind in vaccination. And we need to figure out, we continue to work on this, but we all, you as providers, us as policymakers and federal government entities, need to figure how to improve this, because it is still lagging behind, it's not improving. Next slide, please. So there are many issues with the data, starting with that. And you saw maybe in bypassing that in some areas it says based on 60% of the data or in 70% of the data. Because we don't have all the data on race or ethnicity. We at the CDC get the information from the health departments, which, by the way, get the information from the pharmacies or the providers. And the information doesn't always come complete. When we talk about social determinants of health, when we talk about health equity, one of the tenets of improvement is to know who are we targeting and for what purpose, so we can better serve them. If we don't have good information up front, it's really hard to get the right services to the right groups of people. That is why we have been working on this really hard. We developed our Chief Health Equity Officer, developed the principles for reducing disparities in vaccination and achieving health equity. And you have these ones here in this slide. You can read them after the fact, because as I show you in the next slide, there are still big differences in this country. These maps are hard to explain in the 5 seconds that I have left. But in the map in the left, what I'm trying to show you is that in areas that have less social vulnerabilities, so less poverty, more education, more access, people are getting vaccinated at higher rates. In the map, except in Texas, that we don't get information by county at the level that we need, because they have a law that prohibits them from sharing that information with us. When we look in the map on the right, we see a similar phenomenon. And you look at the New England area, the Northeast, or some of the big cities in the bi-coastal areas of the country, and you are going to see that there are high vaccination rates in those areas. And the cases are not necessarily as high. We knew that, we expected that, but we need to be able to change this. And that's why we need to ask for your help. Next slide. We need to be prepared for these conversations. Time and time again, when we do surveys and go national and ask the communities, who is your most trusted messenger? Always the clinicians come first. Always the clinicians come first. So we need, as healthcare providers community, to choose to get vaccinated and get the message out, but being prepared to engage in effective conversation, because there is so much disinformation out there. It's crazy. You have seen it, I have seen it. There are things that we never expected that we will have to answer when talking about vaccines, but we do. So we need to make this vaccination the new normal. I know that many people said, oh, we are waiting. Actually, we know between 3 and 5%. So they were waiting for the vaccine to be fully approved. Well, now it is. So now is the time for them to be vaccinated. We know that there is a segment of the population that says, Not now, not ever. And we don't have any particular good tools to work with them in that. So we have developed many resources, next slide, please, that are, next one too, available for you to get yourself ready. One of that is we have contracts and partnerships with many different organizations, the American Academy of Pediatrics, the National Hispanic Medical Association, where we are working with them to engage with the providers so we can get the vaccines in your offices and with the people to be vaccinated in your office on a regular way as for any other condition. But at the same time, we know that that's not easy. The vaccine was not easily breakable in doses that could go to your office, but all of that is changing. And that's what we keep telling people. What we said a month ago or 2 months ago is different today. One, because the science changed. Second, because we're in a different epidemiological place. And third, because we are trying to learn as we go. So we have these resources for you. And next slide, we have these resources for your communities in cases that they don't speak English or they prefer to speak in Spanish. We have a whole website in Espanol for those of us who may want to read better in Spanish. So that's all that I wanted to highlight today. And let's move to the next and final slide. Thank you very much. And now we are ready to really hear the great people that is in this panel to address questions from you. Thank you.
Thank you, Dr. Montero. Let me just, let's see if we can get our speakers on, everybody. And put the slides down. We can have a discussion. We're going to have a discussion now among all of our speakers. Thank you. And let me just remind everybody, if you'd like to ask a question, we're very interested in hearing or seeing your questions from the audience. If you'd like to put them into the Q&A box. I have a couple questions that I wrote down. Dr. Montero, just before we start with everybody else, someone had wanted a clarification on whether on one of your slides, you talked about the total population versus the population 12 years or older. And the person who wrote the question asked, are there children under 12 that are getting vaccinated? Is that why you had
No, actually that's why
could you clarify that? Yes.
So actually that's the reason why we have that, because people under 12 are not vaccinable. Is that a word, or I am making up a word? Since we cannot vaccinate people under 12, when we started this, the states, the jurisdiction asked us, because you're going to be posting our data, don't tell us that we are not vaccinating anybody. Just count the people who is eligible for the vaccine. That's the reason why we break it down for everybody's states. So if you want to see the total population, we will tell you 60%, 61% have 1 doses. If you want to look at people who is over 12, 71% of the population, because we excluded those under 12. If you want to look at those over 18, because remember, initially we didn't have vaccine for under 18, that's 73. And if you want to look at the first target that was over 65, that's 91. That's the reason for that breaking down.
Difference in the numbers and the percentages, okay. So let me ask another question to the group. And Dr. Juarez, let me ask you first. I know you're in Nashville, Tennessee, and you've come from the Los Angeles area, so you've been to different parts of the country in your career. What is it about the low-income populations? What do you think are some of the differences that Dr. Montero talked about in terms of access to getting vaccinated? Why do you think that is?
Well, I think it's difficult to make generalizations. In Tennessee, we have a large rural population, or again, rural is most of the state. And in some of those areas, the vaccine rate is still barely approaching 20%. I mean, it's extremely low. It's been very, very challenging to reach those populations. And part of that is there's not even public health clinics in some of these counties. They share a single public health clinic. The number of community health centers is limited. And people, again, have a very independent spirit and the government's not going to tell them what to do. I mean, these are all things that play into this. When we look at rural areas, and particularly in Nashville and with the Latino in Nashville and in the Memphis area that have pretty large Latino populations, access to care and to accurate information from trusted providers has really have been issues. And again, as the two things that have really spurred, and I think that Dr. Montero, the data is really reflects our experience in the last 3 weeks. There are two things that are happening that are increasing the willingness of Latinos in particular to seek vaccines. The first is the Delta variant, and everybody is just really scared of Delta, and the other is back to school. And I think the people are beginning to really think about their children and getting them ready for school, and have been more willing to get vaccinated, get the family vaccinated. And so those are two trends that we're seeing. But just in general, I think the real challenges, again, have been access to care, access to accurate information in Spanish that people can relate to, messages of people that resonate with people. And again, we have really, as our Tennessee SEAL, we have really worked on developing, engaging community partners to help us develop those messages and identify who the best messengers are, and where to do the events, whether they're educational or vaccine events.
Okay, I thank you for that. And I know that you have a lot to say about the populations that you are seeing in rural Tennessee and in some of the cities, but there's some questions about Latinos and this issue of why there is some problems with information getting to Latinos. One question that came up is about the faith leaders that reach Latino community, and some faith leaders, and I'm not going to generalize, but let's talk about strategies. How do you deal with faith leaders, churches, whether they're Catholic or not Catholic, all the different religions that Latinos belong to? How do you deal with them when they are telling their parishioners not to get vaccinated? And one of the comments was, what type of data and how can you get the data to the parishioners at a church so that they can all make their own decisions, and also to maybe persuade the faith leaders to better understand what they're talking about. Laura, do you want to answer that?
Sure. Thank you all for having me, and I'll ask Dr. Rebolledo to follow, since I know she does quite a bit of community outreach. I was actually going to share as one of the strategies or lessons learned from some of our members is to work very closely with not only community-based but faith-based organizations. And that is not only in helping educate them and finding ways to make that information, like Dr. Juarez said, more relatable to them, but also to engage them in the actual execution of getting the vaccinations. It could be as simple as working with, not simple, but we could simplify it to work with them to make their facilities available for a mobile vaccination clinic. I think that could work simultaneously as we're sharing data, as we're sharing information, and finding that common ground. And, again, every situation, every community is going to be different, but I think if you bring faith-based leaders, public health leaders, hospital and health system leaders, they're in it to help the community. And I think usually you can bypass those personal views and just work together to really achieve the goal of increasing the adoption, increasing the knowledge of the vaccinations, and also making sure they're getting it into arms. Dr. Rebolledo, you want to add something?
Sure. Thank you for having me and for allowing me to follow you, Laura. So I think we've been doing a similar strategy in Atlanta, in the Georgia rural area, where we have really tried to engage with community-based organizations who already have established connections from many, many years of working with faith-based organizations to try to help deliver food or school supplies or other sort of a comprehensive health seeking behaviors or instruments for the community. And we've been first, just trying to have a conversation with these faith-based leaders, like from the start when we knew the vaccines were coming, to hear where they're coming from and hear the questions that they have, and have this be more of a bi-directional dialogue, as opposed to necessarily we coming here and just providing facts. And then again, acknowledging that it's okay to have questions, that it's good to have those questions, hearing what they have to say, and then using those common spaces, as you mentioned, Laura, to sort of come to the communities, utilize those trusted areas where people tend to come, whether it be mass or a service, and actually use beforehand. We've done various events where as people are coming into the services, the faith-based leaders allowed us to immunize community members, and having sort of like physicians or healthcare workers on site who spoke Spanish to try to ascertain what questions they may have, and just again create this space of like trustfulness and just being available to the community as well as the organization.
Okay. Dr. Montero, I want to ask you a question about data. Someone asked about the racial ethnic reporting of data. Do you have a sense of how many of the states are now reporting racial ethnic data for COVID-19? I know that there's a big problem because it's never really been mandated. It's optional in a healthcare system, but I think COVID-19 has really taught us how important data is of these populations. And also the second question about the data for racial ethnic reporting, is there any standardized approach? From CDC, maybe if you can tell us how you look at racial ethnic data across the country.
So the quick of the answer is every single state reports by race and ethnicity. It's just that it's at different levels. Some states have more complete data than others. We have had several initiatives to improve the data. Some coming from before the pandemic. We actually pay the states for the data and mortality, and we pay them more when it's complete and timely. So there are many incentives built in the system. Now, the states sometimes have systems that are not fully compatible with what comes from the healthcare providers, but this is multifactorial. In many areas, the information is not collected. Sometimes people don't want the race to be collected. Some people, you ask them, I said, I prefer not to disclose. And that's a big issue. We are looking at that with Native Americans and Hispanics, because in some areas of the country, there is a big overlap between those two groups. And we don't know when people check multiracial, who is what, who is doing what, and that complicates those things. That said, there are standards. The National Center for Health Statistics have developed the national standards, and those are quite well disseminated with all of the different agencies and healthcare organizations. It's just that most of the time people don't look at them, to be honest. People look, oh, your name is José, so you are Hispanic. And it may be that I am Filipino. But people make weird assumptions about race and ethnicity. And in our country with mixed race, that's definitely a big issue. And we have several issues in who counts what. And because advocacy groups are interested in some data, they want to count differently. But we do have standards that are published. And if I may add two pieces of information to the previous question, we did outreach to through our faith-based initiative at Health and Human Services. Personally, I actually did several webinars for pastors where we trained them. But I am not the right messenger to go to the community because I'm a federal employee. People will not like me because I am the government. We need to identify the local trusted people and get those to work with those pastors. It's not that the pastor is going to do all the work or the priest. They can engage, and we need, as Laura, Ms. Castellanos was saying, we need to bring them in and give them some credible work. It's not just that we go and give a lecture and we're done, because that never reaches the goal. So it is an ongoing work and development. This is like the politician, like the canvassers do. You need to keep at this again and again and again, because if not, it's not going to work. And for those asking questions on our data, just Google CDC data COVID tracker, and you will get to the graphics because we update those almost daily. Thank you.
Okay, so that's good to know. So CDC data, COVID-19, for a more standardized approach to our race and ethnicity data. So there's a lot of questions about outreach and about trying to communicate with Latinos, since we now know that Delta is so much more contagious than the other variants, that we really need to step up. And all our organizations that you all work with, what are you seeing as strategies that work? Someone was asking about multi-generational families, choosing not to be vaccinated, and you have a whole family that's not getting vaccinated. How do you, who do you talk to in a big family to make the most impression? Another question about outreach was, how do you deal with small businesses where a lot of Latino workers are? If we could target our outreach, it might be a better way to improve the situation. So let me ask you, Laura, you represent a national organization with executives that are in hospitals around the country. Have you heard of targeted approaches that are working to change the mindsets of our Latino workers and family members?
Absolutely. And I know there's been a lot of questions around the collection of data and improving those practices. And we started an initiative, Pledge for Equity initiative, that was one of the goals, to not only educate for the need of improving the quality of the data, but also providing them the tools around cultural competencies and ensuring that we're finding the most equitable ways in obtaining and sharing that information. And I think to answer your question, these are local problems and these are local solutions. And, I think I personally represent a multi-generational family. I'm a first-generation immigrant where my parents are Spanish-speaking only. And I got to tell you, even translated documents might not impact them. But I'll tell you what, if they see them in the local news, they'll definitely pay attention. So I think it's just a matter of being aware in your community where you have those access points to connect to them. And I know you asked about small businesses, and I think we've mentioned this a couple of times, is to really be able to target, is really being able to engage them to be part of the solution. We're coming to them, with the approach of making sure these vaccinations are accessible. But that also opens the opportunity to continue that engagement, and then for them to become, champions and ambassadors to making sure that they carry through that information. So we continue to encourage, healthcare executives to really think about how to get that landscape of their local communities to help identify those key folks to talk to. And, on the family front, every family is different dynamics, but, ensuring that we are aware of the different generational contexts that we're dealing with will help improve our communications. We're not one-dimensional by any means.
Right.
I don't know if you want me to hand it off to somebody or back.
I'm gonna go ahead and ask another question about outreach. This one was, again, we have a lot of people in our communities that are just hesitant for whatever reason. And either they don't want to take the time or they're not interested in getting the vaccine. And one of the questions when it comes to the people that already get vaccinated, and let me ask you, both of the doctors here, Paulina and Paul, people that get vaccinated can still get COVID-19. So some people are using that as an excuse. How do you talk to people to explain to them why they should get vaccinated if they're seeing people getting vaccinated and still getting sick?
Well, if I may start, I think the way that it's important to talk to patients or community members is with regards to again, what is the ultimate purpose of vaccines? And if we look at a lot of other vaccine preventable diseases, and like we can take something as common or as routine as the flu vaccine, and why do we take it every year? So we know we may still get the flu if we're exposed, but we will get a less severe flu, and we will not necessarily end up in the hospital. And so I think when I've been counseling my patients or family members, when they say, well, you know, like my mom or my neighbor, they got vaccinated, but they still got COVID. We try to have more of the conversation and refocus the messaging around that what the vaccines are really good at, and even with Delta, they're still very good at, is preventing hospitalization and preventing the severe form of the infection that will land you again in the hospital or requiring ICU or intubation. So I think it's, you know, that's sort of like the important thing. If we think about you know, like a common cold, we, you know, if COVID in a sense is like a common cold when we have been vaccinated, then in a way, if we get sick, but we're not going to, you know, we're not going to die or end up in the hospital, then I think that has a very important messaging around that. And I think instead of utilizing more the utility of the vaccines, to emphasize that it's preventing severe disease, and also that the more that people get vaccinated, the better off we will all be as a community. And those still rare events of breakthrough infections will become even rare. And so I think sort of like reframing the messaging around what is the key importance of the vaccine, and that is in preventing severe disease that will avoid you landing in the hospital or avoid you, you know, from needing to an ICU level care and so forth.
Paul, do you have anything to add on messaging that you think works for people that are really stubborn, and just how do you get through to them to listen to you?
Can I respond to that?
Yes.
We have, again, we recognize that not everybody responds to the same message. And so we're using multiple ways for reaching different people. Radio, we do a lot of radio shows, English and Spanish, you know, jazz and gospel. We do, you know, we've done a lot of events with our faith leaders. We've developed sort of scripts in terms of with ideas with gospel and scriptures that they can use to talk about COVID. We try to, again, identify, you know, different things that resonate with different groups of people. We have a youth health ambassador program where we're working with kids so that they can take the message back to their parents. We have, again, we're working with small business leaders. We have them as, you know, talking about what are the issues that they confront in terms of COVID and the, you know, again, masks and no masks and all of these, particularly in a southern state that is not big on masks in terms of all the politics and things. You know, these are all issues that everybody is struggling with, and they're hearing different messages from different people. So what we have really we have tried to now really move towards a one-on-one educational campaign. And we are engaging, again, and since the beginning of COVID, we've had to sort of regroup and change directions numerous times. You know, we were initially funded to help recruit people for the vaccines, for the adult COVID vaccines. And, you know, within a couple of months, again, the vaccine trials had closed and we had to move on. And then we had the vaccines available and we were doing them in these big, you know, stadiums and huge events. And we had cars lined up and drive-through vaccines. And then that dried up and people, you know, didn't see the value of holding just a vaccine event because they weren't getting many people. So we have sort of regrouped and said, look, with people that are still, you know, hesitant about getting vaccinated, we need to meet them on a one-to-one basis. And so now we're going to community events, we're setting up tables, we're having volunteers who can talk to people about their concerns. And we're working with our vaccine partners to be at these events too. So, you know, if it convinces them to have a ready opportunity to get the vaccine. The other thing that we're doing now is we're contracting with small community-based organizations. There's Muslim and Latino organizations that, you know, have a sort of really a relatively small niche, but again, there's the vaccine uptake rates in those groups are still low. So we're working with them to go door to door, to talk to people. We have an educational process for training volunteers. We start with, one of the important things is to be non-judgmental, and not to argue with people, to respect their opinions, but not to, to also provide them with the information and, so that they can hear from another source, because they're probably getting their information from one or two sources, and that those sources may not be really great information. So again, it's really multiple strategies. We're changing constantly, but we think now the really, with those that have not been vaccinated, the best approach is to meet people one-to-one, to be there to answer their questions, and and then to help them get the vaccine if necessary. To really to work with our vaccine partners to make sure that they get to those individuals.
I'm going to switch the subject here. One of the questions had to do with your slide, Dr. Montero, on the different variants, and Delta being one of those variants that doesn't respond to monoclonal antibodies. And is that been a big problem? Have you noticed, or has CDC been aware of this? I hadn't heard about that there are, monoclonal antibody treatments are being given more and more to people as soon as they get the symptoms within 10 days, right? So that people can be stopped from having to go to the hospital by having these great treatments. But is Delta, the fact that Delta is not responding to this treatment, is that happening widespread?
Actually, no. Delta is responding to the monoclonal antibodies that are now out there. One of the reasons why we keep doing the tracking of the variants is to test them against the treatments. And I don't know if Dr. Rebolledo would like to expand a lot on that, but there have been some of the monoclonal antibodies that early on we identified don't work with some variants, and they work better with others. But what we're seeing today, and you see that in Florida and Texas, is quite a lot of success in the management of the patients with the monoclonal antibodies. So,
yeah, I agree.
It's in the variants of concern slide for the South Africa and Delta and the Gamma, the Japan and Brazil. And again, it doesn't say all the treatments; it just says some. So I didn't know how bad it was. That's all I was saying. So it hasn't been that bad. So that's good news.
At least I can tell you on the clinical side, to echo what Dr. Montero was saying, is the ones that were initially EUA approved, those now, like some of the ones that were early on identified, those have we have seen data that shows that they do not work. But the other ones that we have now, Regeneron is sort of like the most popular one. That one we're utilizing for both people who have been exposed, so sort of like somebody in the household who has an exposure, or people who present early on. I think the challenge that we're seeing, and again, every place will be different, but a lot of it is how to mobilize and deploy a lot of these monoclonal antibodies so that we can kind of like get creative about doing them, like, immediately when people get into either the ER or they're seeking care for some other reason. So I think at least in Atlanta, some of the things that we're trying to get creative and struggle and think about how to utilize them more in community venues is, again, sort of like the access, and it all sort of always comes back to access to healthcare, but that they have a good impact, and that at least the ones that we have right now, that they work. It's a good strategy and one of the tools that we're utilizing for people who have early exposure or early disease.
And that's the intent of the slide. It's a certain, because one of the problems that we have in communication with COVID is that people want absolutes. We don't have that. What we said 3 months ago is not necessarily 100% accurate today. The pandemic evolves and science evolves and the treatments evolve. So we need to keep looking at those, and Dr. Rebolledo was absolutely correct. Regeneron is working. So there was something, I don't remember even the brand. We no longer have it. Actually, it doesn't have EUA anymore because it doesn't.
The bamlanivimab, that we,
that one.
the bam that we don't want.
Okay. Well, I know that And for people to know that are on our call, how important it is to know that the government is paying for these treatments and for the vaccines. It's free to people. So there's, you know, that's an incentive for people to get treated if they have symptoms. And I know that the federal qualified health centers, the monoclonal antibodies were sent to them, as well as infusion centers in your cities. And I don't know if you have any sense in Atlanta or in where you're at, Laura. Are you in Chicago or I'm not sure.
I'm in Washington, D.C.
Oh, you're in Washington, D.C. Okay, I thought you were, well, I know you work for the American Hospital Association. And Paul in Nashville and Dr. Montero also in Atlanta. I don't know if you have any sense of how the private doctors have been working to get the monoclonal antibodies too, because from our organization, we've had doctors call us and ask how they can get connected to the infusion centers. I know there's a large website for the National Infusion Centers. And I also know HHS has been in contact with us from the Assistant Secretary for Response and Preparedness and Response. And I think that the clinics were supposed to be working with the private doctors. And I don't know if you're in your cities, are they you know, collaborating to get the treatments out to the different venues? You mentioned emergency rooms and other places. Paulina, do you know, or?
So I know we're part of Grady Memorial Hospital, which is one of our county hospitals. We have a site for giving them in the ER, and the same thing with different hospitals within the Emory healthcare system. And I know some of the other private hospitals in the Atlanta area, they also have access to monoclonal. I don't know how it is more for like local, smaller private practice offices. Like I'm not entirely sure how they're connecting, but I know we get a lot of calls both from the Grady side as well as the Emory from community practices asking if they can, how do they refer patients in. I think the problem that we're seeing in the South and in many other places is that we are overwhelmed by the amount of patients that are testing positive. So it's a matter of basically supply and demand, unfortunately.
So a couple of things on that, if I may. So we have a federal system through Asperger, the Assistant Secretary for Preparedness and Emergency Response, whatever Asperger means.
Yeah,
so
Asperger.
It has been evolving as well. So at the beginning, when adalimumab was the monoclonal antibody that we had, it required a whole infusion center setting with all doctors there. Nowadays, we are seeing some states and jurisdictions are setting up infusion centers and libraries because just the sheer number of patients. In some states, they are considering doing general prescribing by the state health official in the state. So patients are covered and can go to one of these centers. So every jurisdiction is doing it differently. We are making it available to all of them. So this is a partnership with the healthcare system at all levels. It doesn't have to be a hospital. It doesn't have to be an infusion center. And we have all of that information in the HHS website. But the Hospital Association has done some of the outreach as well and have been partnering with all of us on this.
Laura, did you want to say anything about that from the hospital side? How you're working with the community doctors?
Absolutely. You know, one of our great partnerships is working with the state, local, and metropolitan hospital associations, much closer to the ground in regards to, you know, how they're obtaining. We're also working with the supply chain professional membership group, so supply chain leaders, to keep them informed. You know, Dr. Montero said it's, you know, integrate, it's working with the healthcare system at every level. So, you know, we continue to track, you know, good strategies, different stories in regards to, you know, how to best get it trickled into all aspects of in healthcare settings. But, you know, we're still learning, and the partnerships we have with the states are very important to continue that flow of information.
Yeah, I would think, Dr. Rios, that the private physicians, the small private physicians, probably aren't going to adopt this. Many of them don't even provide the vaccines. They just refer to the pharmacies, just because the administrative work and what they need to do to operate this is just beyond what they are really able to do. And so it's not so much that they can't do it, it's just that it's really not cost effective for them to do it.
Yeah, no, I agree, but I know in some states, and we just had a meeting, one of our chapters in California had a meeting with the public health department. They're actually funding private practices to be able to help them with the infrastructure needed to, you know, the refrigeration, for example, for the Pfizer and Moderna vaccines, and other infrastructure staff needed to actually sit there, you know, for the infusion to take place. You need a nurse or somebody trained to work with the infusions. So yeah, totally agree. But, you know, there's another question that we're now back to school, and there's some questions about the pediatric population and the kids going back to school, and you know, school. I'll just say the school leaders, whether they're teachers or school nurses, how do you get them to be more effective in reaching our families about vaccines and getting vaccinated? I mean, we have to take it, you know, get these messages out to the Latino community from all angles. Have you seen that happen? Do you have any suggestions on what they should be doing? Anybody?
Well, in a state where we have a legislature that is both anti-vaccine and anti-mask, and a governor that has basically been non-committal in supporting that, it's really put a lot of pressure on the local school districts to, you know, to come forth and, you know, put, again, most of the larger metropolitan school districts have adopted vaccine or masks, you know, in the school environment for everybody, teachers and students and staff. But again, they're getting a lot of pushback. You may have seen, we've been on the news, the national news around this, you know, where again, you get angry parents, you know, coming to these school board meetings and attacking healthcare providers who are testifying and that sort of thing. So, I mean, it's a very heated discussion, but I think that what we're seeing is that schools have an opportunity, again, to help educate, again, and send, you know, children, but with families as well. But even in a state like Tennessee, where there's a low vaccine uptake and there's a lot of resistance, there are other measures. And I think it's really important for teachers, even when they face the real resistance about mask wearing. You know, the other measures, it really takes us back to the beginning of the pandemic. You know, it's social distancing, it's testing, it's taking temperatures when kids are coming in. It's this whole, it's really all in ventilation. You know, it's all of these things. It can all add to, you know, in terms of reducing the risk of transmission. So even in a state like Tennessee, we want to tell teachers and educators what they can do to help reduce the risk, even in the face of, you know, the strong resistance, both to vaccines and to wearing masks.
Yeah, no, it's frustrating, but I think the challenge is that the organizations and all our partners and the champions that we have with our Vaccinate for All and many organizations across the country that are not Hispanic are aware of the importance of the lack of access in our communities. I think one thing that COVID-19 has impressed upon people is how important essential workers are, for example, in our communities, and how they had to keep working and be faced with more exposure and thus getting more sick. So we have a lot more deaths and hospitalizations and mental health issues, anxiety in our Latino and Black communities, Native American communities. And that means we have many more challenges on how to get more messaging out. Dr. Montero, there was another question on data. Do you have any latest data on the death rates of the COVID-19? And given that Delta is seen as very contagious, have the death rates jumped?
So we do have it. I don't want to quote it from memory because then I will misrepresent the data. But if, again, Google CDC COVID data tracker, and look at the tab, and it will take you right there. One thing that I have been asked several times in the last week, even by the media, is if the mortality rate in children is quite high. And actually, we are seeing more cases, but the mortality rate is not higher. What the problem is that we have more cases. So it will tie to mortality, but mortality rate has not dramatic, is not based on the data that we have today, is not higher than from the previous strengths.
Okay, well, that's
And Dr. Rios, well, I just checked this. We're back to over 1,000 deaths a day nationally, and the death rate continues to increase every day. But again, those, the national numbers really mask the local, regional death mortalities that we're seeing in Florida and Louisiana, Mississippi account for a large percent of those deaths.
And I think if I can just add one point about the children and sort of what one of the attendees was asking about the frustrations and how can we better protect children and empower families, is again around a lot of that messaging that has been, like it has been dynamically changing about how COVID affects our children or it doesn't affect our children. And I think, initially in the pandemic, one of the silver linings that we all thought, at least myself as a parent of a 4-year-old, was like, well, at least it's not affecting us children as much. And all of that, as we've learned with Delta, all of those things have changed. And sort of like to what Dr. Montero was saying, why has it changed? We don't know necessarily if Delta affects children in a more severe way, but largely children under 12 are unvaccinated. So they're gonna be more effective by this strain that is a lot more transmissible. And then the other piece is that before we had our children more, either there was a lot of like virtual schooling or they tended to be less congregating with each other. And now a lot of that, as mask mandates have been, eliminated, or everybody's back to school without those protective measurements, then obviously we're seeing increased disease transmission in children. So I think it's important for providing that information, and again, trying to emphasize how that has changed. And children can, yes, they get sick or severely sick less often, but they can get very severely sick and they can have complications. And really the best, while we get them vaccinated, our best strategies that we have to protect them is to mask them and to empower parents and give them the information, and try to work with our community-based organizations to, again, that work closely with school districts to try to provide those informations. And when we have the opportunity, again, through these direct contacts in vaccination fairs, or through churches or other, just sort of like be another point of contact to sort of like emphasize those messaging to parents and children. So I think another one last thing before I call it quits for this question is the other important piece that I think parents sometimes it has not been as communicated, is that because we've relaxed our mitigation strategies with masking, we're seeing cases of other respiratory infections that we typically see in the winter, particularly with RSV. We've seen those rebound over the summer. And so we're having this sort of like the perfect storm of having more obviously unvaccinated kids contracting COVID as they go back to school, and on top of that, other respiratory viruses that are circulating in the community. And so again, another reason why this is really our best tool to try to protect them and to give parents information so that they can feel empowered, even if their particular school district maybe will not, and our different legislators and governors are not, providing these life-saving measures, that we can give them the tools and the information necessary to do by their families.
And if I may, Dr. Rios, one
Yes.
second. So as we see across the country, regardless of political positions, more and more school districts are looking at the science and making the right decisions. And that is happening at the community level. And each one of them is choosing to look at the messages and message their communities in ways that works for them and their values. I saw somebody talking about this vaccine is your shot to the right to get education, or something to the tune of that.
Yeah,
so for those who are talking about rights, well, my right to education, my way to exercise my right to be educated is to get the vaccine, and things like that, that allows us to understand the sensibilities and the philosophical positions of people that may disagree with us in many different ways, shapes, or forms. In our website, we offer all the menu of activities, but it has to be tailored at every school district.
Right.
And with many governors issuing supporting laws that prohibit that action, it's interesting to see what is happening in the field, because people see their children being sick and they don't want that to happen. And then discussing what is the priority, is the education or the sports? So you were not even going to school. Now you can go to school. Please don't play high contact sports for 2 months, 3 months, while we get a vaccine for the kids under 12. And by the way, get those over 12 vaccinated. Use the mask and lead by example. Use the mask and lead by example for all of the adults, teachers, anybody who gets into the school. And that's the way that is allowing this dynamic to change in many areas around the country.
Yeah, I think it's so important to get more messaging. And Paul, you mentioned you have a radio show, or is that from the medical school, or is that part of your?
We do a lot of, again, we do presentations on some of the local radio stations. We have a regular on one. We do, again, we have what we call Wellness Wednesday on Facebook Live. We have other, again, just regular media and social media events where we're providing updated information. And one event is having our community person talking about what she's hearing and trying to have people who can help respond to those. So again, it's just a lot of different activities addressing different messages, targeting different audiences. You know, it's, again, it's just, it takes one strategy doesn't work. You know, it has to really have multiple facets to it.
Yeah, I have to say that we're also trying to do as much media as we can. We have contracted with at least 3 different media companies because they're different in working with different sponsors to actually train doctors and other members in our organization. The National Hispanic Medical Association is very interested in having more media messaging that is positive and based on science that Dr. Montero was talking about, and the data from CDC. And I think all of us need to do as much as we can to communicate the positive messages and the impact of vaccines, the positive impact of vaccines, and to try to counter some of the messaging that we are seeing in social media. For example, people are believing things that are not accurate. Let me just ask if you all could give us one last word. We're at the end of our webinar tonight. This has been great to hear about the Delta variant, and I understand that there's more variants on the way. I don't know, Dr. Montero, if you have any information on when we're going to see the next one, but I think that COVID-19 and these, I really should say something about the mutations, right? We now know that more people that are not vaccinated are part of the reason why the mutations are happening, and that we do need to get as many people vaccinated as possible to stop this wave of variants coming into our homes and our families. But let me just ask Dr. Montero, would you like to say something? This is just to close out the session. I'll just ask everybody to say some closing words.
Yes, sure, I will start. So we are all scientists in this call. We're all providers of health. We know that science changes and changes every day. What the pandemic has brought to us is this light speed of change, because we have invested so many resources in trying to identify things and keeping track live of things that we couldn't before. We need to keep that in mind in the way that we speak, in the way that we present, and in the way that we educate. Because what we said a year ago doesn't hold ground today. In general, still, keep our distance, wash our hands, use the mask, and those of us who are eligible to be vaccinated getting the vaccine is what is really going to get this pandemic under control. But it requires most of us, if not all of us. Really, we are in this together as a society, as a country, and as a world. If we can vaccinated everybody else, the strains are going to continue to happen there and may come here. So we have vaccines that are amazing, incredibly good. We think that it was going to be this good, and they are. We have treatments, but if we can prevent it, it's way better.
Laura, you want your closing statement, please?
Sure, absolutely. Part of the work that I do is around workforce safety and how do we engage our workforce in these efforts. And I just, there's a very difficult reality that a lot of our healthcare workforce is dealing with in regards to pushback and, just the population getting used to mandates. So we're focusing on education and all the right things. But I think, in order for the well-being of our workforce, to really try to put forth the effort to create a safe environment, as well as a well-informed environment. Just anecdotally speaking to some of our hospital members, they're just starting to see an increase of just disgruntled or kind of aggressive behavior. So, protecting our workforce is just as important. So that's a different angle, but that's quite a bit of the work that I do and wanted to share.
No, thank you from all the hospital leaders that you represent. Thank you very much for being a partner here tonight. Paulina?
I think I will add that one of our best resources are still to try to engage more of the community as our community-based, our local organizations, and really having a good understanding that, as everyone here recognizes, Latinos or other communities were not a monolith. And so having being creative and adaptable and recognizing that if something is not working, like adapting to something different in efforts to really try to address and being flexible with our communication around and our messaging, and flexible with our hours and willingness to sort of provide, different venues or information sessions, both in English and Spanish at different times of the day to sort of catch different members of the community, but sort of really working together and utilizing, I think, those tools are community-based organizations to really get our messages across. I think there tends to be a lot of disconnect, and I will say that for myself, from being a doctor and being mainly in the hospital, and a lot of the times not necessarily knowing how to really reach our communities. And so I think this pandemic in a lot of ways has really opened our eyes to, in some way, understand the disconnect and really the work that needs to be done so that we can do a multifaceted pronged approach. And so I think utilizing some of those tools and also just I think I've learned a lot from just listening to when I do vaccine pop-up events and doing testing events, just really listening, because things that I would think are concerns from individuals, there's probably a lot of things that I was like, oh wow, I never really thought that that's why somebody didn't want to get vaccinated. So being humble and being open to listening, I think this is really the only way out of this. And obviously, I think we will be better at communicating and better at giving people information around vaccines and why this is really the way out of it.
Great. Well, thank you for that. And Paul, your last word.
So one of the challenges has been trying to stay ahead of the curve with COVID and all the changes that are occurring. The next major challenge that I see on the horizon is flu season. And we're going to have flu, the common cold. We have this RSV virus, COVID, the allergies. I mean, these all have a lot of them have very common symptoms. And people are going to be that are getting these symptoms aren't going to know what's what. And that's going to cause a lot of issues, both in terms of probably more at the primary care level, but also emergency rooms. And how we're going to set up to respond to these, the test, how healthcare system is going to respond to it, I think is very important to start the planning now, because I could see just a deluge of people going to see their healthcare providers and bringing with them the flu, the colds, of COVID, and all of this, and being just hotbeds, the healthcare facilities being hotbeds of transmission. So I think again, we've put together sort of a one-page flyer that has the symptoms of each of these 5 different viruses, and to help people begin to focus on it, because I really think it's going to be a very important thing that's coming up, and we just need to be ready for it.
Okay, well, thank you. I totally agree. I want to say that my last comment is the National Hispanic Medical Association's Vaccinate for All is looking for more champions from different communities. The Latino community is not, the same, and we really need people that are from the Northeast and the South and the Southwest and the Midwest. And we're working with everyone. You can go to our website, www.nhmamd.org, and to sign up to be a champion, and also to get this recording, and to also get the information for our next COVID webinar, which will be next month. The last Wednesday of the month will be on women's health. And I don't think the slide is showing, but it is going to be about COVID-19 and women's health. I want to thank everybody for being here tonight. I want to thank all our sponsors. I want to especially thank the staff, and I want to thank all of you, the speakers, and all the participants. This recording will be on our website next week. And here's the slide to show you it. The COVID-19 briefing for next month will be on the impact on pregnant women, mothers, and children. We're hoping that we have more good news about the Delta variant finally leaving, and hopefully the cases and the hospitalizations dropping over the next month. So we'll see where we're at. I just want to thank everybody again, and thank you very much for your time. I know we went over, but this is a very, very good discussion, and I think everybody enjoyed it. Thank you very much. Good night. let people come in.
All right, we are good to start, Dr. Rios.